Good morning, everyone. Today I'll be talking about the outflow tract anomalies in the pediatric population and the role of transesophageal echocardiography in it. So talking about the utility of TE. So where can TE help us? It can help us in the preoperative period, the intraoperative period, the postoperative period, as well as in interventional procedures. So in the preoperative period, it provides us with detailed morphology of the outflow tracts, which are not seen on transthoracic echocardiography, especially in older children or adults. In the intraoperative period, it helps us to confirm the diagnosis in the pre-bypass period. It assesses for the adequacy of repair immediately post-bypass, and it also detects any residual obstruction or regurgitation. And in interventional radiology, it can guide us for catheter-based valve implantations. Talking about normal anatomy, first the conotruncus. So the term conotruncus refers to the outflow tracts of both the ventricles. Its components are the subarterial regions, which is also called the infundibular, the semilunar valves comprising of both the aortic and the pulmonary valves, the great arterial roots, and the proximal trunks. And anomalies in this region are among the most common congenital heart defects. Coming to the normal semilunar valve anatomy, so it is a 3D structure. 3 leaflets attached to the arterial root in a semilunar fashion. The commissures, they separate the leaflets, they extend from the center to the periphery, that is from the ventricular arterial junction to the sinotubular junction. The annulus, again, it's a diagnostic construct representing the most proximal attachments, not a discrete anatomic ring. And the interleaflet triangles are extensions of ventricular myocardium between the sinus of Valsalva. Coming to the left ventricular outflow tract first, the anomalies related to it. First, we have the valvular aortic stenosis. So this is the most common anomaly of the LVOT. The etiologies are bicuspid aortic valve. It is the most common. Then we have the unicuspid aortic valve, a dysplastic tricuspid valve, or a hyperplastic annulus. And these are often associated with other left-sided lesions like coarctation of aorta or hyperplastic left heart syndrome. Coming to bicuspid aortic valve, its incidence is about 0.4 to 2% of the general population. There are 2 leaflets instead of 3, often with a raphe, which is fused commissure. And the fusion types are the right and the left coronary fused, which is the most common, comprising around 70% of the cases. Then we have the right and non-coronary fused, which comprise around 28%. And the left non-coronary is quite rare. T evaluation of a bicuspid aortic valve. Usually the views that are used are mid-esophageal aortic valve short axis view from 30 to 45 degree. This determines the fusion type and the leaflet orientation. We can also use the mid-esophageal aortic valve long axis view from 120 to 140 degree. It assesses any doming and thickening of the leaflets. Diagnosis is best confirmed in systole when the valve opens. Usually it appears like a fish mouth appearance. And a raphe often is present. It can make a bicuspid valve appear tricuspid in the diastole phase. Coming to the unicuspid aortic valve, it could be unicommissural or acommissural. Unicommissural usually has one patent commissure with a teardrop opening. The posterior commissure is usually fused. Acommissural, there is a central orifice with no distinct commissures, although this type is rare. These children often present with severe stenosis in infancy, and on TE it appears as a thickened dysplastic leaflets with eccentric opening posteriorly. Then coming to the Doppler assessment of aortic stenosis, usually we use the continuous wave Doppler, which is essential to measure the peak gradient. For proper alignment, we have the deep transgastric views or the transgastric long axis views, which aligns with the flow. It uses the Bernoulli's equation, which is delta P is equals to 4 into velocity square. The limitations is that the gradient depends on the flow. So any low output state or a poor LV function may mask severe stenosis. So we have the planimetry method to measure the valve area. We use direct tracing of the anatomic orifice area, which is in the mid-esophageal short axis view during systole. It is helpful when Doppler gradients are unreliable, like in mixed stenosis or regurgitation or low flow states. The challenge is that it requires high resolution 2D or 3D imaging to identify true leaflet tips. And 3D TE allows alignment of the cut plane exactly at the leaflet tips for more accurate planimetry. Coming to grading of aortic stenosis severity, although this is not specific for the pediatric population, we have mild, moderate, severe based on the peak velocity, the mean gradient, and the valve area. It is given by the AHA and ACC guidelines. Next, we have the subvalvular aortic stenosis. So this is obstruction within the alveoli below the aortic valve. It is often progressive, rarely diagnosed in neonates. The types are, it has a discrete fibromuscular ridge, which is the most common type. There could be tunnel stenosis, it is a long segment, or there could be accessory mitral valve tissue, and it is usually associated with a VSD, coarctation, or Schoen's complex. On TE, the best views are mid-esophageal long axis view and the mid-esophageal 5-chamber view with antiflexion. So a thin linear ecodensity on the septal surface extending to the anterior mitral leaflet can be seen, and there's turbulence around the membrane. Complications of subaortic stenosis could be, it leads to aortic regurgitation because a high velocity jet from the membrane strikes aortic leaflets, causing thickening and damage. There could be LV hypertrophy, which is secondary to pressure overload. There could be mitral valve damage if the membrane extends onto the anterior mitral leaflet. And the surgical goal for us would be to resect the membrane before significant aortic regurgitation develops. Then we have the tunnel type of subaortic stenosis. It is a more severe form involving a long segment of fibromuscular narrowing, often associated with a small aortic annulus, hyperplastic. So on TE assessment, we can measure the length of the narrowing, the annular diameter, and also the mitral aortic continuity. This requires more aggressive surgery, usually a conorastin procedure, than simple resection. Coming to supravalvular aortic stenosis. This is obstruction at the sinotubular junction above the valve. Most common etiology is mutation in the elastin gene on chromosome 7. It has a strong association with Williams syndrome. And the types are the hourglass type, which is the most common. Then we have a membranous type and a diffuse type, which is hypoplasia of the ascending aorta. On TE, the views used are mid-esophageal long axis and mid-esophageal ascending aortic, short or long axis. We can see thickening and narrowing at the sinotubular junction, and the coronary arteries often get dilated or tortuous due to exposure to high systolic pressures proximal to the stenosis. The ostia may also be obstructed by the thickened ridge. Then we have aortic regurgitation. The congenital causes of AR are a bicuspid or quadricuspid valve, fenestrations, or aorto-LV tunnel. Acquired causes could be post-valvuloplasty, subaortic membrane jet damage, endocarditis, or root dilation. Usually, it leads to volume overload of the left ventricle, and on TE, our goal would be to determine the mechanism, the severity, and the LV response. Grading the AR, usually this is done in adults. So we measure the vena contracta. A vena contracta width of the jet at its origin more than 6 mm in adults is considered severe. Then we have the jet width by LVOT ratio, more than 65% again is considered severe. The pressure half time less than 200 milliseconds is again considered severe, or there is a holodiastolic reversal in the descending aorta. Again, we have the aortic root anomalies. So the causes of root dilation could be Marfan syndrome, Loeys-Dietz, or Ehlers-Danlos syndrome. There's a risk of dissection or rupture in these patients. Then we have the sinus of Valsalva aneurysm. there's weakness of the aortic media. Usually the right coronary sinus is involved, which can rupture into the right atrium or the right ventricle. And on TE, we can see the sinuses, the ST junction, and the ascending aorta in the mid-esophageal long axis views. So this is a ruptured sinus of Valsalva. Usually the presentation would be a continuous murmur and heart failure. The rupture site most commonly is into the right atrium or the right ventricle, and on T there's a windsock deformity which can be seen. Now coming to anomalies of the right ventricular outflow tract. So the most common would be the valvular stenosis, which accounts for 80 to 90% of the cases. Then we have branch stenosis, supravalvular or subvalvular. Coming to valvular pulmonary stenosis, this is the fourth most common congenital heart disease. Usually we see doming of the leaflets, which are thin leaflets with restricted motion central orifice, and they are amenable to balloon valvuloplasty, or they could be dysplastic, thickened nodular leaflets with a hypoplastic annulus. These usually respond poorly to balloon valvuloplasty, and they often require surgery. So on T, we can see it in the mid-esophageal RV inflow-outflow view, the mid-esophageal aortic valve short axis view focused on the pulmonary artery, or the deep transgastric RV aortic view. On T, we can assess the leaflet thickness and doming. We can measure the annulus. On color Doppler, aliasing can be seen at the valvular level. For spectral Doppler, we use the deep transgastric or the mid-esophageal views, which align with the flow. And usually, post-stenotic dilation is common in the main pulmonary artery. Then we have double chamber right ventricle, that is DCRV. So there are abnormal muscle bundles which divide the right ventricle into a high pressure inlet and a low pressure outlet. So these are hypertrophied septoparietal bands. They are highly associated with VSDs, often perimembranous. And on T, we can see it in the mid-esophageal RV inflow-outflow view. It shows the muscle shelf, and color flow shows turbulence within the RV cavity, not at the valvular level. So this is T of DCRV. So we can look for two chambers in the mid-esophageal four-chamber or transgastric views. We can measure velocity across the muscle bundle. VSD is often located in the high pressure chamber, shunting usually from left to right. And so in surgery, we usually resect the muscle bundles, and post-op TE must confirm the relief of obstruction in these cases. Then we have supravalvular pulmonary stenosis. This is stenosis of the main pulmonary artery or the branch PAs. The common etiologies are Williams syndrome, Alagille syndrome, congenital rubella, or post-surgically, example at anastomotic sites. The limitation with T is that distal branch PAs are hard to visualize, so upper esophageal views are best for proximal branches. Then we have pulmonary regurgitation. Common etiology is post-repair of tetralogy of Fallot, usually after a transannular patch. It can also be seen after valvuloplasty or an absent pulmonary valve syndrome. Sequelae is that it leads to chronic volume overload, leading to RV dilatation and dysfunction. And on T, our role is to assess the severity and the size and function of the right ventricle. Again, grading of pulmonary regurgitation. So a jet width of more than 65% come to the pulmonary valve annulus suggests severe. A PHT less than 100 milliseconds again suggests severe. If there's holodiastolic reversal in branch pulmonary arteries, again it's considered severe PR. Now these are the common interventions that we do for the aortic valve. It can be balloon valvuloplasty. It is done for congenital stenosis, and in TE we monitor for acute aortic regurgitation. Then we can do surgical valvotomy. This is direct incision of the fused commissures. We have something called the Ross procedure. Here the pulmonary autograft replaces the aortic valve and a homograft replaces the pulmonary valve. We have the Konos procedure. There is enlargement of the aortic root or LVOT for tunnel stenosis. And we have valve replacement, which could be mechanical or bioprosthetic. Talking about the Ross procedure, so here the patient's own pulmonary valve is used as autograft and moved to the aortic position. The advantage is that autograft can grow with the child and no anticoagulation is required. In T, our role is to assess the competency of the autograft, which is now the neo-aortic valve, assess the homograft in the RVOT for stenosis or regurgitation, and also check for coronary reimplantation sites.
Okay.
In post-op TE, in a case of LVOT anomaly, our checklist would be to see for any residual gradient, peak as well as the mean. Look for the valve competency. If there's any new aortic regurgitation, look for the ventricular function, global as well as regional, which could be because of coronary ischemia. Look for a VSD if associated and check for patch leak and any complications like iatrogenic VSD or mitral injury. The common interventions in RVOT anomalies are a transannular patch, which is used in tetralogy of Fallot. It relieves stenosis but causes free PR. Then we have the valve sparing repair. It preserves the annulus to prevent PR, but there's risk of residual stenosis. We can use conduits like Rastily. This is an RV to PA conduit. You can use homograft or Contegra, or Melody or Sapien valve for transcatheter pulmonary valve replacement. Talking about specific anomalies, tetralogy of Fallot. So the anatomy here is, there are 4 components of it. First is a VSD. It is a large non-restrictive malaligned type. There's RVOT obstruction, either at the valvular or the subvalvular infundibular or both. There's overriding of the aorta over the VSD, and there's RV hypertrophy, which is secondary to pressure overload. So on T, usually the mid-esophageal 5-chamber and the mid-esophageal aortic valve long axis views are used to see the VSD and the aortic riding. We confirm whether it is perimembranous or subaortic. Then override, the degree of aortic override is confirmed, which is crucial for surgical planning. And color Doppler helps us in assessing the shunt direction, right to left, left to right, or bidirectional. For RVOT obstruction, we look for hypertrophied muscle bundles, usually causing infundibular stenosis. The pulmonary valve annulus is assessed for its size, and any leaflet dysplasia or hypokinesia is seen. Usually the mid-esophageal RV inflow-outflow or the mid-esophageal aortic valve short axis view is used. And pulmonary valve annulus diameter, it helps us to predict the need for a transannular patch. Talking about pulmonary artery size, so the importance is that adequate size of the MPA, the main pulmonary artery, and the branch pulmonary arteries is vital for surgical success. The views commonly used are the mid-esophageal aortic valve short axis view or the upper esophageal views for the branch PAs. The limitation in T is that distal PA branches, especially the left pulmonary artery, may be difficult to fully delineate, and Z-scores are often calculated based on transthoracic or MRI data. But T confirms the patency and gross size intra. Coronary artery anatomy is also crucial here. The LAD could be originating from the RCA and crossing the RVOT. The mid-esophageal short axis view is usually used and scanned distally into the sinuses. And it should be visualized for the origin and course. And if any ambiguity exists, then the surgeon must be notified immediately. So for TOF repair, our surgical goals would be to close the VSD, redirect the left ventricular output to the aorta, relieve the RVOT obstruction, that is by infundibular muscle resection or pulmonary valve valvotomy or using a patch, to preserve the pulmonary valve function wherever possible. So a valve sparing repair is usually attempted and achieve a PRV-LV of less than 0.7 post-repair. To look for the VSD patch integrity on TE, we check for the patch perimeter for residual shunts, usually mid-esophageal 5-chamber or a deep transgastric 5-chamber or a mid-esophageal long axis view is used. And if there's a small leak, a high velocity jet could be observed. In case it is a low velocity jet, then we should realize there's significant shunting going on and it requires immediate repair if restrictive gradient exists. Then talking about residual RVOT obstruction. So our target is to minimize the RV to PA pressure gradient. Usually it should come down below 35 millimeters of mercury, and a continuous wave Doppler, usually across the RVOT or the pulmonary valve or the pulmonary artery, is used to measure. And if a high gradient is obtained, it suggests inadequate muscle relaxation or localized narrowing at the patch or annulus, and this requires immediate revision. In case there's pulmonary regurgitation, it can be seen on color flow in the mid-esophageal aortic valve short axis and mid-esophageal right inflow-outflow views. We can assess the jet width, the pressure half time, and holodiastolic flow reversal in the pulmonary artery. And if there's severe PR, usually it is tolerated acutely, but it leads to long-term RV dilation and failure. So the long-term sequelae of TOF could be chronic pulmonary regurgitation. This will lead to progressive right ventricular volume overload. There could be RV dilation leading to tricuspid regurgitation and eventually right ventricular failure. There could be arrhythmias, ventricular tachycardia, often related to RV scarring along the patch lines. And the intervention would be usually a pulmonary valve replacement, often in the adolescent or adulthood. So to summarize, in the pre-op, our focus should be on the coronary anatomy, the PA size and the VSD margins. Post-op, VSD closure integrity and relief of the RVOT obstruction. Our primary concern would be to ensure minimal residual RVOT gradient, less than 35 millimeters of mercury, without severe VSD leak. Next, we have the transposition of great arteries. So here the anomaly is the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. So there are two parallel circulations, the systemic being deoxygenated and the pulmonary oxygenated. For survival, these patients require mixing either through a PFO, PDA or VSD. So T in neonatal TGA before the arterial switch operation. So we focus on the mixing sites, that is the ASD or the VSD. We look at the atrial septum, evaluate the size and flow across the PFO or ASD. A balloon atrial septostomy can be performed under TE guidance to enlarge the ASD for adequate mixing. The usual view is the mid-esophageal four-chamber and mid-esophageal bicaval view for ASD or PFO assessment. Post-arterial switch operation, in the TE we look for the neo-aortic valve. So now the native pulmonary valve becomes the neo-aortic valve. So we assess for both stenosis and regurgitation immediately post-bypass. Stenosis is often mild, and if there's severe stenosis, it suggests there's some technical issue or annular hypoplasia. And regurgitation, mild ARS acceptable, moderate or severe requires investigation. For example, it could be because of leaflet trauma or commissural tear. Talking about coronary artery transfer. So we need to visualize the coronary origins from the neo-aorta. Look for any flow disturbances at the reimplantation sites. Usually the upper esophageal aortic arch view is used. And any regional wall motion abnormality in the left ventricle suggests ischemia due to osteostenosis or kinking. In the neopulmonary artery, here the native aortic valve becomes the neopulmonary artery. So our focus would be to check for obstruction at the above the valve, supravalvular stenosis, at the Lee-Comte anastomosis. So the mid-esophageal aortic valve short axis MPA view or the upper esophageal views for pulmonary artery branches are used, and continuous wave Doppler across the neopulmonary artery is used to measure the gradients, and any significant gradient requires surgical revision. We look for any residual shunts, VSD if present, it ensures successful closure. We look for patch integrity. PFO or ASD is seen, and we look for any residual left to right shunting because it could lead to volume overload later on, and we ensure that the ductus arteriosus is closed. Next, we have the truncus arteriosus. So it is a single arterial trunk which arises from the heart, and it supplies both the systemic, pulmonary and the coronary circulations. A VSD usually is always present, and is large and non-restrictive. And the semilunar valve could be a single truncal valve, often dysplastic. Our surgical goals here would be to close the VSD, separate the left ventricle from the truncus, pulmonary artery detachment, close the PA origin from the truncus. We place a RV to PA conduit, we connect the RV to PAs, and we repair the truncal valve or replace it in case of severe regurgitation. So post-repair, we check for the patch integrity across the VSD, usually in the mid-esophageal 5-chamber or the deep transgastric views, and the neoaortic valve should be re-evaluated for any regurgitation or stenosis, and it must guide the valve repair or replacement decision. Coming to the RVPA conduit in case of truncus arteriosus. So in the stenosis, we measure the gradient across the conduit using continuous wave Doppler. For regurgitation, we evaluate the conduit valve for pulmonary regurgitation. Usually mid-esophageal RV inflow-outflow or the deep transgastric RVOT views are used. Upper esophageal views can help us with distal PA stenosis. And in the long-term conduits, they often calcify and stenose and requiring replacement later. Then we have double outlet right ventricle, DORV. Here, both the arteries, aorta and pulmonary artery, they arise entirely or predominantly from the morphological right ventricle. And a VSD is always associated with it because it is the only exit for the left ventricle. So there's a wide spectrum of anatomy, and the surgical approach is entirely dependent on the VSD relationship. So the location of the VSD is crucial. It could be subaortic, it could be subpulmonary, it could be doubly committed, or it could be a non-committed VSD. So the diagnostic challenge for us is that the double outlet, it can be missed if the T plane is not precisely aligned. The views commonly used are the mid-esophageal long axis, RV inflow-outflow, and the aortic valve short axis views. And we can use 2D or color Doppler to confirm that the VSD connects the LV to the preferred grade artery for tunneling. Usually an intraventricular tunnel is formed for this repair. So there's a creation of a baffle, a tunnel from the LV through the VSD to the systemic great artery, which is the aorta. And then the role of T is to critically assess for tunnel obstruction. Continuous wave Doppler gradient in the deep transgastric view can be used along the tunnel path, and any significant gradient mandates immediate revision. To summarize, so the in truncus arteriosus or DORV, so we look for truncal valve regurgitation and RVPA conduit integrity. The VSD artery relationship should be described pre-op, and post-repair, the intraventricular tunnel gradient should be seen. And the VSD anatomy, it determines the surgical repair, and TE helps in confirmation of its adequacy. Talking about 3D TE, so we can visualize the semilunar valves. Coming to the aortic valve, we can precisely see for the leaflet number, bicuspid or tricuspid location of the rapase, and accurately use planimetry to calculate the valve area. Pulmonary valve also can show us detailed morphology, particularly helping in patients undergoing replacement, transcatheter pulmonary valve replacement sizing. The benefit is that it improves on 2D limitations of foreshortening and plane alignment. Complex VSDs can also be seen on 3D TE. In the end phase view, we can visualize the VSD margin from the LV or RV side. Accurate measurement of the VSD size and shape can be done, and it can also be used for transcatheter VSD closure, device sizing and deployment. Comparing TE with other modalities. So comparing it with transthoracic echocardiography, it provides superior visualization in the operating room or patients with poor acoustic windows. Then cardiac MRI, it is superior for quantification of RV volume, the pulmonary regurgitation fraction, and distal PA or coronary anatomy. Although it is a non-invasive gold standard for follow-up. Again, CT angiography is excellent for bony and vascular anatomies like in coarctation or pulmonary artery stenosis. And other uses of T are in infective endocarditis. Like congenital heart lesions, they especially have an increased risk for infective endocarditis, especially valvular stenosis or regurgitation. So T can help us to detect vegetations, it can assess the extent of valve damage, and it can also identify abscesses, which can lead to root dilation. So the outflow sites like aortic valve, pulmonary valve, the conduits, patches can all be visualized for infective endocarditis by TE. Any mass in the LVOT or RVOT can be assessed, like myxomas, rhabdomyomas, or fibromas. We can differentiate a fixed obstruction from mobile masses, and it can help us to define the relationship to the surrounding structures like valves, septum, and any risk of embolism by the mass. Then T in Fontan circulation, we can assess the systemic ventricular function of the LV or the RV. We can ensure competency of the mitral or tricuspid valve regurgitation. We can also evaluate for systemic outflow tract obstruction, aortic or neo-aortic valve in these patients. T can also be used in the intraoperative resuscitation, like it provides immediate real-time feedback on cardiac motion. We can quickly confirm tamponade, hypovolemia, or mechanical failure. It can also tell us about adequate chest compression effectiveness. In the post-op period, we can monitor the ventricular function. We can qualitatively assess the systolic performance. We can adjust the RT assessments based on anesthesia, inotropes, and volume status, and also the diastolic function. Okay. Also, in post-operative shock, T is crucial for rapid diagnosis of circulatory compromise. Potential causes could be acute valvular regurgitation, any residual shunt, tamponade, or coronary ischemia. Talking about T and long-term follow-up, so it can be used in re-intervention. It is used during catheterization or reoperation for residual or recurrent stenosis or regurgitation. And we can do serial TE for high-risk patients, especially in infective endocarditis surveillance. The limitations of TE in outflow assessment is that the distal structures, especially the distal branch pulmonary arteries, are not visualized properly. There is high risk of suspicion for coronary artery course and specific views. T is just a screening tool, not the gold standard. And patches, surgical conduits, and calcified valves can obscure our visualization. Also, the gradients and the shunting may be masked by low cardiac output. Talking about T probe and its placement safety. So we're talking about the pediatric population here. They have a smaller esophagus. There's increased risk of airway compression and hemodynamic instability. So we need to use smaller pediatric or micro probes in infants. We need to continuously monitor them for the heart rate, rhythm, the SpO2, and look for esophageal trauma, although it is rare, but it can be serious. So to summarize, the outflow tract lesions that T helps us with are valvular aortic stenosis. We can look for leaflet morphology, gradient, new AR post-valvuloplasty. In subvalvular AS, we can look for membrane or tunnel location, the distance to the aortic valve, any secondary aortic regurgitation. In supravalvular AS, we can look for stenosis, severity, coronary osteoproximity or obstruction. Aortic regurgitation will determine the mechanism, the severity, the root size of the aortic valve. In the RVOT, for pulmonary stenosis, we can determine dysplasia versus doming, gradient, annulus measurement. For DCRV, we can locate the muscle band, we can calculate the gradient across the muscle. Pulmonary regurgitation, the severity, the RV size, the function. In TOF repair, we can look for the coronary course, VSD patch leak, residual alveotic gradients. In complex outflow tract lesions, like in DTGA, we can look for neo-aortic AR, coronary transfer sites, neo-PA stenosis after Lecomte maneuver. Truncus arteriosus, we can look for truncal valve regurgitation or RV2PA conduit stenosis. In DORV, the VSD artery relationship, which will help us determine the tunneling plan and the intraventricular tunnel gradient. Yeah. So the core T takeaway messages are: T is indispensable for intraoperative assessment of surgical adequacy in congenital heart surgery. We need to check the anatomy first, either with 2D or 3D, and then the function via Doppler gradients or shunts. Communication is key, so the T findings must be communicated clearly and immediately to the surgeon for prompt revision. And any residual stenosis or major regurgitation are the primary surgical failures that the RTE should be able to detect. Thank you.